Okay, so today I've been asked to give a talk on SBRT for liver tumors. So obviously historically there's been a very limited role for radiation for unresectable hepatocellular carcinomas, mostly because there's perceived radioresistance of hepatocellular with radiation. And there's obviously, it's very difficult for radiation oncologists to be involved in care of these patients because historically we were just not involved. But there's been definitely an increasing role for radiation in certain cases of hepatocellulars, and a lot of these studies have actually started in Asia where, I guess they drink heavily and have a lot of hepatocellulars. So they have tried to figure out a way to treat these patients. And over the last 10 years, there's been a lot of studies coming out, both in US as well as Asia, that have looked at whether radiation can be an option for hepatocellular cancers. So there's been an improvement in the way we can localize liver tumors. So this is largely due to improved imaging. A lot of the radiologists have figured out that a combination of MRI and PET scan, we can really localize how these tumors appear in the liver. And there's obviously improvement in radiation technique where we can deliver radiation in a very high doses to a focal area in your body and spare the normal tissue. And you can the key is to deliver doses that can kill the tumor, but yet spare some of the normal liver parenchyma that's surrounding the liver. So I think with all this new technology in radiation oncology, we've sort of have played increasingly a role in treating unresectable hepatocellular. So in Louisville, we do stereotactic body radiation therapy, which is essentially a way of delivering a high dose of radiation to a small area. And it really depends on the technology that you have, the quality of the machine, and a way to identify or visualize the tumor before you treat the patients. And we can do all of that with our radiation machine these days. So this is a picture of a Varian. I think this is probably a trilogy or something like that. But anyway, this is a Varian machine. It's got a CT mounted to the side and an X-ray that's also X-ray machine that can actually detect and match up to the bony anatomy of the patients. There's several challenges in doing radiation for liver. Number one, it's very difficult to see liver tumors on a CT. It's mostly because the quality of the CT that we can get on our radiation machine is not as good of a quality. And there's definitely a change in the liver size with respiration, meaning that when you breathe, your liver actually can move quite a bit. So when you're treating patients with liver mets or hepatocellulars, you think you're treating 2 centimeters, but then with respiration, you're actually treating 5 centimeters because they sort of move up and down with respiration. So there is also liver essentially abuts a lot of the critical structures in your bowel, stomach, and things like that. So these are dose-limiting structures. So you have to be careful of not overdosing the important bowel that are around the liver. And obviously, with every treatment, we don't just do one treatment for these patients. We typically do 3 to 5 treatments, and there is some change in anatomy between each treatment fraction. So these are some of the ways in which we can target liver tumors. So what we do is we use these small fiducials that are on here, and this is with our interventional radiologist, helps us to put these near the tumor, and you can see it on our x-rays that are generated through, it's very difficult to see on this picture, but you can kind of see on our CT that's done in our radiation machine, these bright little fiducials that are seen here. So this is how we line up the tumor by lining up to these fiducials. And I think you can kind of see it here as well. So this is some of the ways we know that we're treating the tumor by lining up to these fiducials. Another way we try to limit the liver motion is by putting in a compression belt around your belly. So you put a tight compression belt, and as you breathe, it forces you to breathe very shallowly, so you're not moving your liver as much during respiration. So the first published liver experience was done approximately almost 20 years ago, and this was a study, sort of a crude study using old radiation techniques, in which they treated patients with varying doses of radiation dose, and what they showed is that in certain cases you can cause the tumor to have a growth arrest, and in some cases you can reduce the size of these tumors, and sort of this was actually a study that was done after the very first lung SBRT experience. So we sort of moved from brain to lung to down to the liver. So I think the dose that they used here is definitely lower than what we would normally use for lung cancers or brain tumors, but obviously even at these doses, you can see a response of these tumors. So this is a study that was done by Dr. Dawson at Princess Margaret. So she was sort of a pioneer in our NRG world with these treatment. And what she tried to do was try to dose escalate these patients and do it in a more modern radiation, using more modern radiation technique, meaning you are really focused on the tumor and sparing the normal liver tissue around it. And what they found was that patients who are getting liver SBRT can lead to a good control or acceptable control rates, and these patients tumors can be controlled with SBRT alone. So since then, there's been more and more studies that have come out, and there is a varying degree of local control rates that you see here. It's after, and what people are trying to do is push sort of the limits of the radiation dose and see what the maximum dose can be delivered without affecting their liver function. So that's the key is, and what they try to do is they're essentially pushing the dose higher and higher, and there is definitely some correlation between the amount of dose you give and the local control rates with very acceptable side effects. So this is typically what you see with liver SBRT. So this is a patient with cirrhosis, hepatocellular carcinoma. You can see this hypodense lesion in the liver. When you do a PET scan, it sort of lights up very brightly. So in our center, what we do is we do a PET scan to localize the tumor, and we also do get an MRI just to make sure that it's matching. And then we put in a fiducial, and we treat this tumor with 5 treatments. And typically what you see is that this hypodense lesion on a CT doesn't necessarily change very much. But when you do a PET scan, you see that the PET scan is not as bright. So this is sort of how SBRT, this is how the imaging characteristic after SBRT. And you also follow these patients with AFP levels, and in majority of the cases, you also see a decrease in AFP levels as well. So in fact, this patient was, I think, lived to about 15 months. He ultimately died from, his liver cirrhosis. But in any case, I think in his case, probably helped him live longer, because he was really not a candidate for any other, any other treatment, really. So this is a study, like I mentioned, higher the dose is what we try to achieve with liver. And this is a study from Colorado. This is a dose escalation study from anywhere from 36 gray to 60 gray in 3 fractions. So this is actually similar to the dose that we would use in the lung, 60 grays in 3 fraction. And the key here is that this group in Colorado was very good about patient selection. So they didn't treat big tumors. They tried to treat tumors that are about 15 cc's in size, which is about 2 to 3 centimeters in diameter, depending on which dimension you look at. They also use respiratory gating, which means they're limiting the volume that you're treating to as low as possible. And what they found is that for tumors, with all the modern techniques, all the respiratory gating, you can actually reach a very high percentage of local control. So this is actually a complete response on a PET, not necessarily a partial or stable disease. So I think dose escalation with these guys have shown to be very effective with very minimal toxicity. And the key here is to treat smaller lesions. Now, the group at Southwestern also did something very similar several years back, and they also saw very similar results. If you give lower dose, the response rate is not going to be as good, but when you push the dose to a higher level, you get a very nice local control rates. So I think that probably is the key to liver SBRT, is that you have to be able to deliver a certain amount of radiation dose to control the tumor. And when we talk about local control, we're talking about in SBRT world is a complete response. So I think that's what you can expect from SBRT with these types of doses. So this is sort of a just more data with dose escalation. People have also done single fraction SBRT, but in any case, there's varying degree of very high rates of local control when you push the dose to a higher level. So there's also some interest in SBRT for biliary tumors. These are cholangio carcinomas, whether it's intrahepatic or extrahepatic cholangiocarcinomas. And in patients who are not candidates for surgical resection or I think SBRT can be an option. So we used to do, with our IR guys, intra-arterial liver-directed therapy, but I think SBRT is definitely another option for these patients. There's not as much data on biliary tumors because there's just not enough patients in each center. But you can achieve similar rates of local control as you would for hepatocellular if you push the dose to higher level. So we also see a lot of unresectable liver mets from colorectal cancers. In general, their survival rate, it really depends on the amount of disease they have in the liver as well as the extrahepatic disease. But obviously, chemotherapy alone has some response rates, and historically, if they have metastatic disease, their 5-year survival tends to be poor. So as our previous speaker alluded to, the gold standard for liver-directed therapy has been RFA plus minus TACE or yttrium therapy. But I think SBRT has a role in these situations as well. We have a multidisciplinary practice where we sort of discuss all these patients with our IR guys, with our GI guys, and liver surgeons, and we kind of look at where these tumors are in the liver. And I think that really location of these spots are really determine whether they are going to get, whether they're able to get RFA versus SBRT. So there's certainly limitations to RFA. Obviously, if the location is very critical here, and the size, there is certain size limits that we see with liver with RFA. So if it's along the stomach, diaphragm, or obviously some of the important structures, then RFA is sort of difficult to do. This is sort of what I consider to be the no-fly zone with RFA. So obviously, if there's a tumor here or along the major organs, I think we tend to sort of discuss patients to get SBRT rather than RFA in our multidisciplinary setting. So there is RFA morbidity. I think overall there is relatively low rates of morbidity with RFA. It really is operator dependent. So if you have somebody who's, here, I mean, obviously, our previous speaker has done tons of these, so they probably has very low complication rates. But if you go out in the community hospitals, I mean, I think RFA really needs to be done by somebody who does it multiple times and has a lot of experience with it. But if you look at if you pull the data, all the RFA data, and look at the complication rates, there is, relatively low complication rates, but it is definitely real, I would say. And we see that in our center as well. I mean, our guys do this all the time, but there's unfortunately some complication rates here. So there's been a head-to-head comparison with RFA versus SBRT. And as our previous speaker said, if the tumor is 3 centimeters or less, I think RFA is very equivalent to SBRT. But when it gets to be bigger than 3 centimeters, I think there's some data suggesting that SBRT may be slightly better than RFA. And obviously this is not, this is something that really needs to be looked at in a multidisciplinary or multi-randomized setting. So I think in overall, at least from our experience, SBRT tends to have slightly less side effects than RFA. And it's certainly an option in patients where the RFA cannot be delivered safely if it's adjacent to or critical structures. So in our world, we are looking at, there's a couple of trials through NRG where we're looking at combining sorafenib with SBRT, similar to the trials that are being done in with sorafenib and yttrium or those types of data. But I think SBRT has a role in patients in which if the patients have good performance status and they have a good oligometastatic of just few liver lesions, I think SBRT can be an option for these patients. So in conclusion, SBRT for liver is very well tolerated. It can reach very high local control rates, up to 90 to 100%. It's very safe, I think, in our experience. It's very effective. And SBRT may not be appropriate for patients who have some advanced liver underlying lesions. But I think these patients need to be discussed in a multidisciplinary setting. And I think I think this is still sort of an emerging area, but I do think that SBRT certainly has a role in certain population of our liver patients. So with that, I'll take any questions. Thank you.